Panchajanya, the divine conch of Bhagavan Sri Krishna, which was blown during Kurukshetra, indicating the start of Dharma Yuddha that followed. There are all the efforts were done for the establishment of Dharma. Dharma was kept over personal relations and motives. Keeping the same motive in mind, our organization will work towards establishing the same importance and necessity of following and imbibing Bharatiya culture, accepting our roots, and making people realize the true essence of Ayurveda, not only as a treatment modality but also a way of life. All these while walking in the path of Dharma. Hence the motto Shreyam Bharatiyam Arogyam Ayurvediyam. The founder of this organization started this because we felt the need to spread the knowledge of Bharatiya culture, Ayurveda, the truth of history of Bharata Shastra and values to all Shastras of people in every corner of the world. Also the founder, being Ayurveda aspirant, know the inside out of today's medical field. Hence the aim to make the people aware of this and also try their best to solve this on to go. So we are having 10 wings which are effectively working on these principles and objectives. They are Ahilabai wing, Swami Vivekananda wing, Karnatabala wing, Govardhana wing, Ashwini wing, Narada wing, Kautilya wing, Vedavyasa wing, Nalanda wing, and Sanjaya wing. These comes under Vedavyasa wing and it is also association of this Panchajanya. Today we are having Vaidya Rajasree ma'am, who is currently working as an assistant professor and pediatric consultant at Atreya Ayurvedic Medical College and Hospital, Dodballapura. Ma'am has experience in handling more than 75 neonatal care at birth independently and assisting more than 100 cases during MD curriculum. University first rank in MD Kamararutya and gold medalist for academic excellence in UG colleges. Thesis work on a clinical study on the therapeutic effect of Vidanga Krishnadi syrup in Purishaj, Purishajakrimi with respect to Enterobius vermicularis. Ma'am has presented so many papers in the national and international conference and secured Best Scientific Paper Presentation Award in 2014 conducted at AHMA and PAMPA. Ma'am has secured Best Paper Award in Scientific Cancer Scientific Paper Presentation competition held as a part of Kamarabriti 2020, a Day 2 national webinar on common urinary system disorders in children by Bharatiya Ayurvedic Vidyapita, Pune. Faculty of Kamarabritya in AMA Academy, Kerala. Ma'am has won a Lakshmi Amma Memorial Gold Medal for academic excellence in BMS. So we would glad that ma'am is present in our today's session. Ma'am, I would like to hand over the session to you, ma'am.
Thank you, Panchajanya team, for the opportunity. Glad to be in association with you. So shall I start over with the session?
Yes, ma'am.
Hope my slides are visible and I am audible good.
Yes, ma'am. You are audible.
Okay. So the session allotted as per the points in examination point of view of third year BMS. So we are dealing with birth injuries and congenital anomalies, being the syllabus points in Kaumarabhritya part B of the syllabus. The syllabus is a bit vast, so I would try my best to stick on to the time limit and highlight on the very important topics of this syllabus points. And if you have been referring the previous question papers, you might have seen that so many questions are being asked from these points and a bit more important in both clinical and also the examination point of view. So these are the syllabus points which are included and which will be covered in the today's session. So I'll start with birth injuries. So, as the definition goes, birth injuries, they are an avoidable and unavoidable trauma sustained by infant during the process of birth, which simply means that any trauma or any unpredictable situations which happens during the process of birth is called as a birth injury, and it can occur antenatally, intrapartum, or during the resuscitation, which means it can happen just before the birth, during the birth, and just after the birth. So the birth injuries are classified as traumatic birth injuries or hypoxic ischemic birth injuries, where traumatic birth injuries are known as the physical trauma, maybe forceps delivery causing a trauma, for example, or any of the fractures, and hypoxic ischemic injuries, which occurs due to the lack of oxygen and blood circulation, which we will be dealing with in detail. So, the common risk factors or the etiology which is causing a birth injury are primiparity. So, in a primiparous mother, there may be a difficult labor or cephalopelvic disproportion might cause it. Short stature of the mother, prolonged labor. So, the prolonged duration of the labor, which is again giving chances for a birth asphyxia or so. Malpresentation of the fetus, like apart from cephalic presentation, any of the presentation, instrumental delivery with forceps or a vacuum extraction, which may lead into a birth injury. So the traumatic birth injuries are majorly classified as soft tissue injuries, head and neck injuries, injuries to face, nerve injuries, bone injuries, and intra-abdominal injuries. So, in the syllabus point of view, we'll be dealing with Upashirshaka, which is correlated as Caput, Succidanum, Cephalohaematoma, facial paralysis, Erb's paralysis, fractures, Shwasavrodha or Asphyxia neonatorum, Ulvaka, meconium aspiration syndrome as correlated. So, Caput Succidanum, this is a very common condition seen in the newborn, like in the very normal births, we see this Caput Succidanum, which resolves by itself. So, as defines, Caput succedaneum is a diffuse edematous non-fluctuant swelling of soft tissues on the presenting part of the scalp. It occurs after prolonged engagement of fetal head in the birth canal or during a vacuum extraction, and it is present at birth and subsides in first 24 to 48 hours. So this is the swelling of it is a non-fluctuant swelling, to be very specific, and it is present at birth and it subsides in first 24 to 48 hours by itself. And the specific feature is it is not limited by the suture line. So we cannot say that where it starts or where it ends. It is not limited, and it is a diffuse swelling, and it has poorly defined margins. And it is a subcutaneous collection of seroanginous fluid, which means there is mixture of blood serum and the blood. Now the cephalohematoma, as we see in the picture, it is limited, right? So when we are comparing the pictures, it is limited by the suture lines, and it is the subperiosteal collection of blood. So the other one was subcutaneous collection of the seroanginous fluid, and here it is subperiosteal collection of the blood, and it is due to the rupture of superficial veins between the skull and periosteum. It is a cystic or fluctuant swelling, as differing from the Caput succedaneum, which was a non-fluctuant swelling, and it is limited by suture lines, and it is commonly seen over the parietal bones, and it is not present at birth. It develops after or over 24 hours of the life, and it resolves after a few weeks. So it doesn't come down within days. It takes a few weeks to for the cephalohematoma to subside, and there are many complications associated, like severe blood loss, hyperbilirubinemia, and in cases of massive cephalohematoma, and skull fractures are associated, and in cases of infection we have to go for drainage and antibiotics. So in the exam point of view, the difference between Caput succedaneum and cephalohematoma are very important. So as we have discussed already, just classifying the differences into like two categories, where the one is a well defined outline, and in the Caput succedaneum it's a poorly defined outline, and the course and the what you say onset and also the remission, everything has been discussed over. So this is correlated to Upashirshaka as told in like Ayurveda. So Upashirshaka is explained in Ashtanga Hridaya Uttara as in the Shiroroga, where it is being explained as Kapale Pavane Dushte Garbhastasya Vijayate Savarno Niruja Shofa Tam Vidya Upashirshakam, where it is clearly told that it is the Vata Tushti which is causing this condition, and the clinical feature is very much explained as Savarno. So it is not having any of the discoloration. It is of the same color like of the normal skin, probably. Nirujaha, there is no pain, and it is a shofa. So there is a swelling or an inflammation, and it is called as Upashirshakam. And the treatment is also being explained. Nave Janmotaram Jade Yoje Dubashirshage Vadavyadhi Kriyam. So the Nava cases, we can go for the Vadavyadhi Kriya because it is caused by the Vata. And if it is Pakwa, so as told earlier, when it is infected, we have to go for, or when there is a abscess kind, we have to go for the drainage. Similarly, in the Pakwa Avastha, we have to go with Vidradivat Chikitsa. So both are explained in Ashtanga Hridaya Uttara. And next, it is facial paralysis. So as seen in the picture, it is a facial nerve injury, and facial paralysis or the facial nerve injury is the most common peripheral nerve injury which can occur, and it is due to the prolonged pressure from sacral promontory during the intrauterine period, and it can be due to the application of forceps during the delivery. So when the instrumental delivery takes place, if the forceps are used and it
Hello.
is help, yes.
I'm sorry to interrupt. Put the slideshow, ma'am. The slides are not changing, I think so, in the live
Okay.
session. So,
In
uh,
excuse me, I am moving it, but
ma'am,
is it?
put slideshow, ma'am.
Yeah, it's in slideshow now.
Oh, it's not changing right now, so that's the reason.
Where we are stuck now?
The it was stuck in the first page itself. Now
Okay,
it's
okay.
changing, ma'am.
Can you see it now?
Yes, ma'am. Above its option, no, ma'am. Slideshow. Can you press that
Yes, yes.
from the current slide?
Can you see? Visible now?
Not, no, ma'am.
So
Just
it's
a second, ma'am.
been, yeah, okay.
Again, you press, ma'am, the current slide from the current slide above.
Now, is it moving?
It's not, ma'am. Better you change the slides in the left scrolling while scrolling itself, ma'am.
Now you can see?
Yes, ma'am. Yes, ma'am. Better you
It's
change there itself, ma'am.
okay. It's visible,
Yes,
right?
ma'am.
You can
Ah,
read it,
yes,
right?
ma'am. It's changing now.
Okay.
Yes, ma'am. It's visible. It's visible.
Okay, okay.
Thank you.
So we were telling about the facial paralysis when it can happen during the application of forceps during the delivery. So when there is an instrument delivery happening and there is a force which being applied over the facial nerve, which can cause the injury, and it happens due to the compression of peripheral portion of the nerve and leads to facial nerve palsy, and it can be present at birth and usually detected on first or second day of life, when a presentation like this is seen in a baby when they are crying or when it is crying, and we suspect for the facial nerve palsy. So the clinical features are expressionless on the affected side, absence of wrinkles over the forehead, flat nasolabial fold, and unable to close ipsilateral eyelid completely, and angle of mouth deviate towards unaffected side on crying. So whatever is seen in the figure is very much appreciated from for the clinical features. And treatment is, so we can give a symptomatic management by protection of involved eye by patching, so to avoid any of the, like, as the eye will be kept open, the eye cannot be closed, so there can be eye patching done. Artificial tears can be used to prevent the corneal injury, and spontaneous recovery take place within first 2 weeks of life when it is a very transient kind of a compression. So if at all it is not being recovered, surgical intervention might be needed after 1 year of observation. So the next one is Erb's paralysis or the Erb's palsy. So this what we have learned already in anatomy, brachial plexus, which is being taught, shown here. And Erb's palsy or Erb's Duchenne palsy is the most common form of brachial plexus injury, and it happens due to the injury to C5 and C6 nerve roots of the upper trunk and occasionally involves the C7, and in 5% of the cases we can see phrenic nerve injury. So as seen in the figure, you can see that the presentation will be when there is a damaged brachial plexus, there can be a disabled arm, and it has the clinical features where there is an adducted and internally rotated shoulder joint, extended and pronated elbow joint, flexion of wrist and fingers. As seen in the figure, you can see that. So whatever clinical features are explained, adducted and internally rotated at the shoulder joint, extended and pronated at the elbow joint, and flexion of wrist and fingers. It is also called as waiter's tip posture, and in this cases, there the absence of morose and biceps reflexes are seen, but the grasp reflex will be intact. So next one is clump case palsy. So as we are discussing about the Erb's palsy, let us just know about Klumpke's palsy too. So the C5, C6, and C7 we have already discussed. So when there is an injury to C8 and T1 nerve roots, it involves the intrinsic muscles of hand and long flexors of the fingers and wrist. So as you see in the picture, there is a claw-like presentation of the hand. So it is known as Klumpke's palsy. Here the grasp reflex will be absent because the intrinsic muscles of the hand and long flexors of fingers and wrist are affected, but the biceps reflex will be intact. So the treatment is conservative management. There can be physical therapy for the passive range of motion is given with the exercises to joints to prevent contractures, and the treatment started after first week of life. So the prognosis often depends on the severity. Mostly the infants recover by 3 months of age. So if there is no recovery by 3 to 6 months of age, they are candidates for the surgery. So next we are moving on to the fractures. Clavicular fracture is the very common kind of a fracture which happen as a birth injury. It occurs during spontaneous vaginal delivery due to the shoulder dystocia or macrosomia, large baby or breech delivery. So it can be complete or incomplete fracture. So incomplete fractures are usually asymptomatic at birth, detected after appearance of swelling in the supraclavicular fossa. So only when we see there is a very evident swelling in the supraclavicular fossa by the second week of life, we get to know that there was an clavicular fracture. And the common symptom seems to be decreased movement of the ipsilateral arm. Many of the times the fracture goes unnoticed. And just it is decreased movement of the ipsilateral arm and there will not be any prominent symptom. It goes unnoticed. And on examination, we can see the crepitus, palpable bony abnormality, and asymmetric morose reflex because there is a less activity of the affected side. So diagnosis can be done through the X-ray, and treatment is analgesics and immobilization. So the immobilization will be done as seen in the figure, and the X-ray might show the fracture as shown in the figure. So the next one is humerus fracture. So this is the most common long bone to get fractured at birth. There is difficult delivery of the extended arms in breech presentation and shoulders in the vertex presentation. So, and also as told earlier, shoulder dystocia, macrosomia, cesarean section, and low birth weight babies, humerus fracture are seen. So these are the risk factors. And the most common site of fracture is proximal end of the humerus. And there can be decreased or absent movement of the involved limb, associated local swelling, deformity, crepitation, and increased pain with the movement. So as seen in the figure, there can be a swelling, localized swelling, there can be deformity in the normal structure of the arm, there can be crepitus, and there is increased pain with the movements. And morose reflex will be sluggish or absent. Treatment, the reduction of displaced fracture by splinting for 2 to 4 weeks in adducted position, and the complication is radial nerve injury. So this is the X-ray figure of fractured humerus. And femur fracture, again, the common fracture of the lower extremity, the long bone, involves proximal half of the femur. In breech presentation or in the C-section, we can see the femur fractures. And congenital hypotonia cases, they are prone to get the fractures. Deformity of thigh can be seen with decreased movements. So traction and suspension of legs in spica cast. So even if the fracture is unilateral, we go for the traction and suspension of both the limbs. So in the fracture of humerus, this is the immobilization done, and the fracture of femur, the right side figure is the way we put in the spica cast. So the next one, a very important birth injury is asphyxia neonatorum. So this part of asphyxia neonatorum we have already been covered in the prana pratyagamana or the neonatal resuscitation part, but still we will go with the asphyxia neonatorum. So asphyxia neonatorum is defined as a combination of hypoxia, hypercarbia, and metabolic acidosis. So when there is a reduced oxygen intake, or when the oxygen supply is being cut off due to, so if the baby is not crying soon after birth, it can lead to hypoxia, which eventually leads to hypercarbia in the body and metabolic acidosis. So this is defined as the combination of three of this. And National Neonatology Forum defines asphyxia neonatorum as baby has gasping and inadequate breathing or no breathing at 1 minute. So soon after the birth, as we call it as a first golden minute, if the baby is not breathing or baby is not crying good, it has gasping and inadequate breathing or no breathing within 1 minute of birth, it is identified as asphyxia neonatorum. And the Apgar score when it is less than 3. And American Academy of Pediatrics defines asphyxia neonatorum as cord umbilical artery pH less than 7, neonatal neurological manifestations as signs of HIE, hypoxic ischemic encephalopathy, and evidences of multi-system organ dysfunction. So Apgar scoring, as we know, we score the Apgar scoring soon after the birth. So normally it should be more than 7. And if it is less than 7, 5 to 6 mild birth asphyxia, 3 to 4 moderate, and 0 to 2 it is severe birth asphyxia. So this is the important cause of developmental and neurological handicaps in term and preterm infants, as we see the cerebral palsy or the sequel of hypoxic ischemic encephalopathy. So this is the important cause of all the developmental anomalies what we get to treat as Ayurvedic physicians too. The way in which asphyxiated baby is managed at birth determines the immediate morbidity and quality of life in the survivors. So how we manage an asphyxiated baby at birth is very important, because that is what decides the child will be leading a good quality life, or the child will be having any morbidities which are sustained for the entire life also. So normally the baby should make vigorous efforts immediately after the birth. So increased pressure in the alveoli promotes the absorption of fetal lung fluid, and also it delivers ambient oxygen to the pulmonary arterioles and causes arterioles to relax. When this sequence of normalcy is interrupted, pulmonary arterioles remain constricted, alveoli remains filled with fluid, and systemic arterial blood does not get oxygenated. As like result of this, tissue oxygen supply decreases, and the survival reflex maintains the blood flow to be more concentrated towards the heart and brain, and try to keep the oxygen delivery stable over there to preserve the function of vital organs. When there is oxygen deprivation which is continued, there is myocardial dysfunction and cardiac output deteriorates, blood pressure falls, and blood flow to the organ reduces. So the clinical features, when there is a reduced oxygen delivery, so there is depression of respiratory drive due to insufficient oxygen delivery to the brain, poor muscle tone because there is again oxygen delivery is reduced to the brain, muscles and organs, bradycardia, tachypnea, persistent cyanosis or low saturation, and low BP from insufficient oxygen to the heart muscles. So diagnosis, we can go with the history for any of the risk factors, physical examination, laboratory test like ABG, and Apgar score, pH, and neurological sequel after this asphyxia and multiple organ involvement. Investigations include Sarnath and Sarnath criteria for the physical examination, and lab ABG, LFT, RFT, serum electrolytes, blood sugar, and for the metabolic causes, and imaging CT, MRI, EEG, and cranial USG. So this is the Sarnath and Sarnath classification, where the asphyxia is classified as stage 1, 2, and 3 as mild, moderate, and severe, where level of consciousness activity, neuromuscular control, reflexes, autonomic functions, and seizures are being checked for the physical features, and it is being classified accordingly. So the treatment of birth asphyxia is, first one is prevention of intrauterine asphyxia. Then, if at all there is a birth asphyxia, so there is a arrest of oxygen supply at birth. The baby did not cry soon after birth. Baby not cried soon after birth. We have to give the supportive treatment. And if at all any complication setting, we have to treat the complications. So the supportive treatment is to avoid the further brain injury. And the first part is initial resuscitation. So we already have covered this initial resuscitation and stabilization of the child. So with the basic steps of resuscitation, then the advanced steps of resuscitation, which starts with like after the basic steps, it goes with bag and mask ventilation. So in case of respiratory failure, mechanical ventilation has to be given, and the PO2, the partial pressure of oxygen, has to be maintained at 80 to 100, and the PCO2 at 35 to 45 mm of Hg. And the child has to be maintained in special care neonatal unit for 12 to 48 hours. It has to be nursed in the thermoneutral environment, 36.7 to 37.3 degrees Celsius, and attached to vital sign monitor to check in the saturation, heart rate, and the respiration. Stomach wash should be done with normal saline and vitamin K 1 mg IM, which is a normal routine. And to prevent hypoglycemia, IV 10% dextrose can be given. So in case of prolonged asphyxia, sodium bicarbonate will be administered, and chest X-ray to exclude pneumothorax and congenital anomalies. And tissue perfusion maintenance is the cornerstone of therapy to prevent the vital organ damage, where dopamine infusion can be given, and the urine output has to be monitored. So if at all now the treatment of complications, if at all seizure setting, we have to manage the seizures, and any metabolic support is required in case of acidosis. We have to go with the metabolic support and correct the abnormalities and avoid hyper or hypothermia. So the child will be or the newborn will be nil per os or nil by mouth in first 3 days in moderate to severe cases, and enteral feeds has to be given, and any signs of necrotizing enterocolitis has to be seen in, and parenteral nutrition will be given in the extreme cases. So next one is Ulvaka Roga, or the correlated as meconium aspiration syndrome, where it is the most common case of respiratory distress in term and post-term infants, where the fetus can pass the meconium in utero or soon after, like during the process of birth, where when as a result of fetal distress. So the causes of this meconium passage in utero can be placental dysfunction, post-mature babies, a small for gestational age babies, or antepartum hemorrhage. High risk of meconium aspiration syndrome is seen in thickly stained amniotic fluid with particulate matter. So we get the amniotic fluid as pea soup appearance when there is a breakage of water. So they and in the newborn there can be yellow staining of skin, umbilical cord, and the nails. So the pathophysiology is basically three, where there is airway obstruction, chemical pneumonitis, and surfactant dysfunction. So the airway obstruction due to the mechanical obstruction of with the meconium particles, chemical pneumonitis, the meconium particles entering into the lung parenchyma and causing irritation, causing the inflammation of the lung parenchyma, and surfactant dysfunction. So again, this meconium particles causing the disruption in the function of surfactant. So that as a result of this actions, that can be atelectasis, air trapping, pneumothorax, right to left shunting, and VQ mismatch, and chronic lung disease. So the clinical features: aspiration in utero during birth or after birth can take place. In utero, we will get to see severe clinical course and thick consistency, like cause usually meconium aspiration syndrome, than the thin stained amniotic fluid. So after resuscitation, initial apnea followed by progressive respiratory distress might be seen. There can be marked suprasternal, intercostal, and substernal retractions and grunting. So when we see grunting and retractions, and also there is tachypnea in the child, we always suspect a respiratory condition, and in meconium aspiration syndrome it will be very evident. And anteroposterior diameter of chest increases due to the obstructive emphysema, and there can be variable percussion note and sometimes wheezy. So this is evaluated, the respiratory distress is evaluated using the Down score. So as explained earlier, the Apgar score and the Down score are very important in assessment and also the evaluation of the respiratory distress. So as opposite to the Apgar score, here more than 7 value is giving the idea of an impending respiratory failure, and 4 to 7 gives respiratory distress, and less than 4 there is no respiratory distress or the child is normal. So in meconium aspiration syndrome, there is a progressive course during initial 24 to 48 hours. It leads to persistent pulmonary hypertension, hypoxemia, and acidosis. Massive aspiration, meconium can be absorbed and excreted through the urine, where there will be a dark brown urine. So this is the X-ray picture of a meconium aspiration syndrome, where X-ray shows bilateral hyperaeration, nodular opacities due to areas of atelectasis and consolidation. Hyperaeration, you can see hypertranslucence of lungs, horizontal alignments of the ribs, and depressed domes of the diaphragm. And usually extra findings, you can see the bilateral findings and asymmetric and non-uniform. So the meconium will be like spread in the cavity. So the management in the delivery room, the first step will be oropharyngeal suctioning with a 12 French catheter before the delivery of infant shoulder, if we are seeing that there is a thin or thick meconium, and then promptly delivered and effective suction after the birth. Thick meconium stained babies who are depressed at birth, which means they don't have a active cry or the activities, they are intubated and meconium aspirated by attaching the endotracheal tube to a negative pressure source. So there can be yellow staining of skin, umbilical cord, and nails, which indicate meconium has been passed 4 to 6 hours before the delivery, where it has been absorbed into the skin. Amniotic fluid is meconium stained. Baby promptly delivered by cesarean section or forceps if cervix is adequately dilated. So positive pressure ventilation should be avoided in the infant until adequate laryngeotracheal toileting done to prevent pushing of meconium further into the small airways. So when there is a meconium stain, we have to do the suction first, or we have to clear the larynx and trachea out of this meconium. Otherwise, if we are giving a positive pressure ventilation, the meconium particles can go further into the smaller airways and lead into further complications. So at birth management, meconium stained baby, if crying vigorously and breathing normally, baby placed on mother's abdomen and handled like a non-meconium stained baby after removing the fluid. In meconium stained depressed or apneic baby, oral cavity, oropharynx and glottis area promptly and effectively sucked under direct vision with the help of laryngoscope by using 12 or 14 French suction catheter as told earlier. Endotracheal intubation can be done, and it is connected to a gentle intermittent suction source to suck out the meconium. At times, saline lavage has to be done to remove the thick particulate meconium. So after effective suctioning, we can go for bag and mask ventilation to expand lungs and relieve hypoxia. If infant's heart rate and respiratory rate are severely depressed, early positive pressure ventilation despite presence of some meconium can be done, because saving the life of the newborn is more important. After transfer to NICU, stomach wash with normal saline to reduce the risk of gastritis and aspiration of meconium stained gastric contents. And the child has to be closely watched and monitored for the development of respiratory distress or onset of persistent pulmonary hypertension. So nursed in thermoneutral environment and oxygen given with the head box. So all the supportive care, what we do after the resuscitation, post-resuscitation care has to be given. IV fluids are restricted to 2/3 of maintenance requirement. Hypocalcemia, hypoglycemia, and hypotension should be looked for and appropriately managed. Assisted ventilation in case of impending respiratory failure. Pneumothorax should be identified and managed by chest drainage. So we are moving on to the Ayurvedic aspect of the birth injuries. Prasava Kale Abhighata Vyadhi. So we can give a correlation which has been explained in Succidanum Sharira 10th chapter. Akala Prahanad Badiram Mugam Kubjam Vyastahanum Murthabhigadinam Kasashwasa Shono Batrudam Vikatam Vajaneti Tatra Pradiloma Manilome. So due to the difficult labor, there can be many conditions which are set in as Muka, Kubja, Vyastahanu, Murthabhighata, Vikata, Shosha, etc. due to the untimely or early uterine contractions or the difficult labor, whatever as explained. So again, this meconium aspiration syndrome can be correlated to Ulvaka Roga, which is explained in Ashtanga Uttara, where it is being explained that Garbhambasa Avamana, the Sleshmana Kandagasyava. So we have already learnt in the normal newborn care that Garbhodaka Vamana has to be done. So when Garbhodaka which is not taken out, it it is stuck in the kanda and it causes Kafadushti. It is causing obstruction in the Rajasree and it is giving the lakshanas like Baddha Mushti Tado Muhyan Roger Balo Abhibhuyade. So there is Hridroga, Akshepaga, Shwasakasa, Chardi, and Jwara, etc. So there can be the child can turn unconscious. There can be as seen like in the seizure, there can be Baddha Mushti, and there can be conditions like Hridroga, Akshepaka, Shwasakasa, Chardi, Jwara, etc. And the Vyadhi is called as Ulvaka Vyadhi, and there is a synonym Ambupurnam or Sahajavyadhi. So Ulbagam, in the exam point of view, it is important. It can be asked, and it was asked repeatedly in the examinations. So the treatment, as explained in Ashtanga Sangraha, it is Chagala Mutra for Srodho Vishodhana. And in Ulbaga, Snana and Abhyanga is like contraindicated. And Vilvadi Panchamula Siddha Grida has been explained as the yoga which can be used in Ulvaga Vyadhi. So this is about the birth injuries. And next we are moving on to the Sahajavyadhi. Sahajavyadhi, so this is correlated as the congenital anomalies. So whatever anomalies which are present at birth are identified as the Sahajavyadhi. So in Charaka Samhita Sharirasthana, it is being explained that Bijatma Karma Ashe Kala Doshe, Madhustadahara Vihara Doshe, Kurvandi Dosha Vividani Dushta, Samsthana Varna Indriya Vaikridani. So due to the Bija Dushti, Atma Karma Dushti, Ashya Dushti, Kala Dushti, or Madhu Ahara Vihara Dushti or Dosha Dushti, there can be different condition which is set up in the child which is causing samsthana varna indriya vaigrita. So in the physical structure or in the complexion or in any of the indriya pravarti or in the anatomical appearance or the structure of the indriyas. So this is what Acharya has explained, where everything is being covered in all the etiologies which are leading into the congenital anomalies are being covered in. And also there is an explanation that yasya yasya hi angavayavasya bija bija bhaga upatapto bhavati tasya tasya hi angavayavasya vikriti upajayade na upajayade cha anupatapat, where it is being explaining about the genetic involvement. So whenever there can be a this can be something related with the genetic conditions even. So many of the syndromes which are set in can present with many of the congenital anomalies too. So these are the two references where we can get an idea, where acharyas have explained about the Sahajavyadhi or the congenital conditions. So the abnormal conditions which are present regardless of the cause are identified as the congenital anomalies or the congenital disorders. So in our syllabus point of view, we have Sahaja Hridaya Vikara, Jalashirshaka, Khandaoushtha, Sanniruddha Guda, Pada Vikriti, and the neural tube defects which are spina bifida, meningocele and meningomyelocele, to be very specific. So first we are moving on to the Pada Vikriti, congenital talipes equinovarus or CTEV. What is being like, there are like two conditions which is given in the syllabus point. One is the talipes equinovarus, the other one is valgus deformity. So as seen in the figure, these are the deformities which are seen as the Pada Vikriti at birth. So there are many kind: equinus, the calcaneus, cavus, varus, equinovalgus, calcaneovarus, and calcaneovalgus, equinovalgus, etc. So it can happen as a combination of these conditions, or the isolated Pada Vikriti also can happen. So these are the various presentations which can set in. So CTEV is congenital talipes equinovarus. So as you see in the figure, so it is also called as club foot. So this is the normal, you can see in the left side the normal presentation of a foot at birth and the club foot. So talipes equinovarus, also known as club foot, it is the foot abnormality in which foot points downwards and inward, and it is present at birth. There involves foot and the lower leg sometimes, and it can be one or both the leg affected. 80% of the condition it is bilateral, and male children are seen to be more affected, and there is a stiff rigid foot of varying degree. There is short or tight Achilles tendon, foot pointing downward, heel turned in, deep heel crease, soft puffy heel pad, wide front foot area, and smaller foot, as seen in talipes equinovarus. So the pathogenesis is, there is crimp fibers which are formed, which are modified myofibroblast, and it have significant elastic recoil, and later on it sets into like a condition like talipes equinovarus. And talipes valgus is, so there is, with the genu valgum there is congenital deformity of the foot is rotated inward, and walking is done on the inner side of the sole. So the diagnosis and treatment: prenatally it can be identified by the ultrasound, postnatally it is very much evident by the physical examination. So if so that this CTEV can be like this talipes equinovarus or the club footers of like different types, where it is milder, moderate, and severe. So in the milder cases, it can be like treated just by the postural correction, which is called as postural clubfoot, which occurs due to the crowding in utero. Otherwise, when there is a much contractions, or when there is a tight Achilles tendon, we have to go for the further consultation. So the clubfoot management is done by an orthopedician. So the basic management is done by Ponseti method, where there is casting and bracing done. So there is periodic casting being done. There is like it can be done soon after the birth, and it has to be periodically changed, where 4 to 8 serial casting will be done, and later bracing will be done for the postural correction. And if at all required, reconstructive foot surgery can be done at the age of 1 to 2 years. So this is the picture of a case where we had got a bilateral club foot, and the first figure is soon after birth. The second one is when they have started with the casting, And the third figure is after the fifth cast. So the club foot can be corrected with the casting and bracing. Later, if at all it is cannot be corrected, or there is a tightness of the Achilles tendon, it has to be like tendon release surgery has to be done, or the surgical correction has to be done in. So this is about the club foot. So the next one is neural tube defect. So neural tube defects are very like sometimes, or to say very much complicated a condition when it is setting in as a meningomyelocilianal, and sometimes asymptomatic when it is set up like setting in, or when it is shown as a spina bifida occulta case. So basically they are classified as primary or secondary, or open or closed. So primary includes meningomyelocele, encephalocele, and anencephaly, and secondary includes meningocele, lipomeningocele, and spina bifida occulta. So primary are usually open and secondary are usually closed. So etiology of this neural tube defect is combination of genetic and environmental factor. When there is folic acid deficiency or folate deficiency in the pregnancy, when the women do not take a folic acid supplement, and when the pregnant lady or the mother is under anticonvulsants, obesity or poorly controlled diabetes in the mother. So this is how spina bifida occulta, meningocele, and meningomyelocele or myelomeningocele can be differentiated as seen in the figure. So spina bifida occulta, it is the birth defect in which there is incomplete closure of spine and membranes around the spinal cord during the early embryogenesis. It is a simple vertebral arch defect due to failure of fusion of posterior spinal elements. So it is usually seen in lumbosacral region. There will be no defects in the meninges, spinal cord, or the nerve roots. And outer part of some of the vertebrae is not completely closed, to be very simple. There are mild or no symptoms there. There can be a tuft of hair seen on the lumbosacral region, which gives you an idea that there is a spina bifida like deformity inside. There is a sacral dimple or sacral pit over the skin which can be seen, and some cases you can see the caudal appendage as a tail on the lumbosacral region. Meningocele, it is a protrusion of meninges through the bony deficit in posterior vertebral arches. Neurological manifestations are usually absent. So usually the clinical features or what we see in the presentation is fluid-filled fluctuant midline lesion, and the transillumination test is positive when you light at a light source, and there is just translucent. It allows the light to pass through. Next one is myelomeningocele, which is the severe form in which spinal cord and nerves develop outside the body and are contained in a fluid-filled sac that is visible outside the back area. So there is discontinuity of the spinal cord, mostly in the lumbosacral area seen. There are conditions, cases like occipital myelomeningocele. We had seen a baby born with an occipital meningomyelocele with a huge sac on the occipital region. So, but usually the myelomeningocele is seen in the lumbosacral area, and exposed deformed neural tissue can be seen with oozing of CSF. Skin, vertebral bodies, meninges, nerve roots, and spinal cord are involved in the myelomeningocele. So the clinical feature is fluid-filled swelling present at lower back or middle back or the neck or in the occiput, as in occipital myelomeningocele. There can be paralysis of lower limbs with deep tendon reflexes and sensory reflexes absent. Poor ability to walk and lower limb postural abnormalities if the child survives and goes through. There can be impaired bladder or bowel control. When meningocele and meningomyelocele comes together, it is called as spina bifida cystica. The other one was spina bifida occulta. So there are two types of spina bifida, and this is how myelomeningocele might look like. And management is surgical repair. So my meningomyelocele has to be, so if a child is born out of meningomyelocele, child has to be nursed in the prone position. It has to be covered with a saline gauze, very sterile saline gauze, and child has to be shifted into the NICU, and the surgery can be done within 2 days of life. And in symptomatic cases where there is a neurological deficit like incontinence of urine or bowel or bladder control is lost, we have to manage it with the neurological approach of treatment. So the next part is CHD, congenital heart disease, or the Sahaja Hridroga, where the Sahaja Hridroga, the classification of Hridroga is Vataja, Pittaja, Kafaja, Sannivadaja, and Krimija Hridroga, which can be identified as Jatotara, like after the birth, which is being set in. And Sahaja Hridroga is congenital, which is present at birth. So It is being told that 8 out of 1000 live births, excluding the patent ductus arteriosus in a preterm or mitral valve prolapse, etc., 8 out of 1000 live births are having CHD or congenital heart diseases. Cardiac anomalies arising as a result of defect in the structure or function of heart and great vessels which are present at birth are defined as the congenital heart disorders. Either they obstruct blood flow in the heart or vessels near to it, or alter the pathway of blood circulating through the heart due to the anomalies in the greater vessels. So this is a scheme of fetal circulation which we have already studied in the anatomy, where we see that there are three bypasses in the circulation, as opposite as in the normal adult. So there is a ductus venosus, which is a bypass in the liver, where the from the umbilical vein the blood is directly drained into the inferior vena cava, and there is a connection between the right atrium and left atrium, which is a second bypass, that is foramen ovale, and there is a connection between the pulmonary trunk and the aorta, that is the third bypass, that is ductus arteriosus. So the congenital heart disorders are mainly classified as acyanotic and cyanotic. Before that, that can be classified as structural, functional, and the positional. But the structural ones are very specific. So CHD can be, or the structural congenital heart disorders can be classified as acyanotic and cyanotic. So the acyanotic one, where there is left to right shunt and outflow obstruction. So the left to right shunts, you can see ventricular septal defects, patent ductus arteriosus, and atrial septal defect. And in the outflow obstruction, when the flow of blood out of the heart is obstructed, that can be pulmonary stenosis, aortic stenosis, or coarctation of aorta. And cyanotic are classified as tetralogy of Fallot, transposition of the greater arteries, and atrioventricular septal defect, of which ASD, VSD, PDA, and tetralogy of Fallot are important as in the exam point of view. So, for the diagnosis of congenital heart diseases, there is a criteria called as NADA's criteria, and they are classified into major and minor criteria. So, the major criteria includes systolic murmur of grade 3 and above, and diastolic murmur, congestive heart failure, cyanosis. Minor criteria is systolic murmur grade 2, and abnormal second heart sound, abnormal X-ray, abnormal ECG, and abnormal BP. So by this criteria, they mean that if there is presence of one major and two minor criteria, we can diagnose them as congenital heart disorders. So NADA's criteria is very important as in the diagnosis of a heart disease. So the general features are very vague, that it can be classified as the clinical features: exercise intolerance, dyspnea, fatigue, palpitation, decreased appetite, feeding difficulties, frequent infections, sleep disturbances, edema, and syncope. So, which doesn't mean it is only at the birth. It is these are the features which can be seen also in the children. So the classification basically in the acyanotic, it is pink baby. It doesn't mean that there will not be any cyanosis set in an acyanotic condition. When compared to the cyanotic cases, the cyanosis is less evident. That is what we understand by the acyanotic. Usually, the cyanosis is less, and the child can be seen as pink. But the classification includes PDA, patent ductus arteriosus, VSD, and ASD. There can be coarctation of aorta, pulmonary stenosis, and aortic stenosis as in the obstructive pathology. The cyanotic, obviously the blue baby, and tetralogy of Fallot, transposition of the greater vessels, and tricuspid atresia is seen. So atrial septal defect or the ASDs are very common, where there is abnormal opening in the atrial septum, which allows the oxygenated blood from the left atrium to mix with the deoxygenated blood in the right atrium. And right atrium receives blood from the superior vena cava, inferior vena cava, and also from the left atrium, leading to volume overload and eventually to pulmonary congestion. So the types of ASD are ostium secundum, ostium primum, and sinus venosus, where ostium secundum is the most common, where there is foramen ovale. Ostium primum, when in the septum, the defect is in the lower position, it is called as ostium primum, and if it is in the upper position, it is called as sinus venosus, and that is least common type. And clinical feature, asymptomatic with murmur detected on a routine evaluation. So the child may be tired during feeding, playing, or eating, shortness of breath, fatigue, sweating, palpitation, and there can be stunted growth or poor weight gain. Diagnosis in auscultation, you can find loud S1 and wide fixed splitting of S2 heart sound, chest X-ray, ECG, and echocardiography, where we can appreciate the type and size of the AST, degree of shunt, and associated defects. So in the management, 20% of like they close, this ASDs close simultaneously as the child grows by itself spontaneously. Medical management can be given, and in the secondum ASD, non-surgical transcatheter repairs can be done. In the primum defects, open heart surgical corrections are done, and surgical management can be done at the school age. And indications of surgery at early age when there is persistent heart failure or evidences of pulmonary arterial hypertension. Next one is ventricular septal defect. As told in the atrial septal defect, when there is an abnormal opening in the ventricular septum, which allows oxygenated blood from left ventricle to mix with the deoxygenated blood in the right ventricle, and right ventricle receives blood from the right atrium as well as the left ventricle, leading to volume overload and the pulmonary congestion. So they are most commonly occurring type of the CHD, and the time of clinical onset, it is always dependent on the size and location of the defect, and there is left to right shunt. So there are two types of classification for the ventricular septal defect, which is perimembrananeous, which is very commonest, subpulmonary, trabecular, and inlet ventricular, and small, moderately restrictive, and large, or very simply small, moderate, and large. So the clinical presentation, large shunt, like it shows fast breathing, feed intolerance, failure to gain weight, excessive sweating, and recurrent chest infections. And examination shows when there is failure to thrive, cardiomegaly, tachycardia, tachypnea, systolic murmur at left fourth intercostal space. And small or moderate ones are very much asymptomatic and sometimes detected on routine examination. So the Swiss cheese defect is like a very hallmark sign in the ventricular septal defect, where you can see there is multiple muscular defects in the ventricular septum, which is very much similar to a Swiss cheese. So hence the name, so as seen in the figure. So the diagnosis is through ECG, chest X-ray, and echocardiography. And the management, the small VSTs closes spontaneously, moderate to large requests like closure, and medical management can be given, but adequate nutrition has to be maintained because failure to thrive is like usually seen along with VST. High caloric diet is advised. Surgical repair can be operative and percutaneous device closure. Early surgery is indicated in the large defects and association with aortic regurgitation. So the next one is patent ductus arteriosus. When there is failure to closure of ductus arteriosus, so usually in premature infants they are very common, and also in infants born to rubella mother we get to see PDA. Oxygenated blood passes from aorta to pulmonary artery and mixes with deoxygenated blood which goes to lungs, increases blood volume to lungs, and pulmonary hypertension and pulmonary congestion. Clinical features, largest PDA or large PDA is present with congestive cardiac failure at around 6 to 10 weeks of age. Mild to moderate presence with frequent chest infections, effort intolerance, and palpitations. So examination shows bounding pulse, prominent carotid pulsations, and continuous murmurs. So that is a hallmark of PDA where there is continuous murmurs. Treatment in the preterm, indomethacin is used. In term, we have to control the heart failures. Small PDA might cause within 3 months of age. Moderate or large require surgical closure based on the condition. And in the cyanotic heart disease, where there is increased or decreased pulmonary blood flow, obstructive lesion or with an abnormal anatomy. So right to left shunt is what is seen there. Deoxygenated blood circulates in the arteries, which is leading into the cyanosis. So tetralogy of Fallot is the commonest cyanotic CHD, and it is a combination of 4 conditions. They are pulmonary stenosis, ventricular septal defect, overriding of aorta over the septal defect, and right ventricular hypertrophy. So tetralogy of Fallot is again a repeatedly asked question for 3 marks, where the combination of 4 conditions has to be seen in. So remember about the 4 conditions: pulmonary stenosis, VST, overriding of aorta, and the right ventricular hypertrophy. Clinical features, child can present the clinical features at any time after birth depending on the severity of the stenosis. It includes central cyanosis, exertional dyspnea, and effort intolerance. During infancy and early childhood, cyanotic or anoxic spells may be the main presenting feature. So child feels comfort in squatting position. That is very important in this tetralogy of palate. Examination, cyanosis with clubbing, absence of CHF, and the normal sized heart can be seen. And ejection systolic murmur is seen in the pulmonary area. So diagnosis again, ECG, chest X-ray, boot shaped heart, and uh, echocardiography. So in the chest X-ray, you can see boot-shaped heart, which is also called as Coeur and Sabut. So which is very particular with the tetralogy of palate. And treatment is management of cyanotic spells, surgical treatment. So you can go for open heart surgery for the intracardiac repair, which is the definite treatment for the condition. And the shunt, which is called as Blalock Taussig shunt, is the palliative treatment in case of the TOF. So the next one is cleft lip or the cleft palate. So as seen in the figure, cleft lip or cleft palate, this is the most frequently encountered congenital anomaly in the craniofacial abnormality. Like all of us might have seen a face with a corrected cleft lip or cleft palate at least once in our life. So it is the most commonest one. And cleft lip is failure of fusion between the medial nasal and maxillary processes. And cleft palate is the partial or total lack of fusion of the palatal shelves, or where there is a non-fusion of the palate, or non-palatine fusion can be identified as a cleft palate. So the classification, it can be isolated cleft lip or cleft palate, which means it can happen cleft lip alone or cleft palate alone, or there can be combined even. So it can be unilateral or bilateral. You can see the defect in both the sides. So in the midline, if it is like it is not fused in, you can see it is being seen in the both sides of the face. It can be complete or incomplete. Same with the combination or the combined cleft lip or cleft palate. Again, the same classification, unilateral, bilateral, where there can be combination of both the cleft lip and cleft palate, and it is again classified as unilateral, bilateral, and complete and incomplete. So the clinical features basically feeding problems, because the baby cannot set in the suction of feeding in the suction for the feeding through the breastfeeding. So there can be feeding problems. There can be nasal regurgitation and aspiration, middle ear infection, speech problems, psychosocial issues, dental problems. So diagnosis usually can be done by the antenatal USG. You can understand that there is a condition, and at birth you can see evidently you can see the cleft lip. But sometimes if only cleft palate is there, we have to go for the thorough oral examination. And also you can see bifidula, pearly white line in the midline of the palate. And treatment, so treatment is like it is a multidisciplinary treatment where the surgery has to be there, the psychological counseling, and also the speech therapy. Sometimes even after the surgery the child tend to have a nasal twang in their voice. So all this conditions has to be addressed by a multidisciplinary treatment. So 3 to 6 months we go for primary lip repair, 9 to 12 months palate repair, 3 to 5 years lip revision, 2 years they go for speech assessment, and necessary interventions will be done. 8 to 9 years orthodontic intervention, if at all there is a derangement in the like teeth eruption or the alignment of the teeth, orthodontic intervention has to be done. 10 years alveolar bone grafting in very severe cases, and 16 years nasal revision. So all this together makes the treatment of cleft lip and palate, along with the speech therapy and also the psychological counseling. So in Ayurveda we can correlate it with the Khandaoushtha and Khanda-Talu, where Khandaoushtha is like explained in Ashtanga Uttara, Tatra Khandaoushtha ityukto Vatena Oshtodida Krita. So Vata is causing the breakage or division of the Oshta into two, and the treatment is explained as Khandaoushtha Vilikhyado Syutva Vranavadajaret Ishti Jyotishmadi Rodra Shravani Sarivotpale Patolya Kakamajya Chatailam Abhyanjanam Pajet Nasyam Chatailam Vadagnam Maduraskanda Sadidam. So first they have told about, so we have to go with the Lekhana, and then we have to go with the Sivana. So and later it has to be treated like Vrana, and they have told about the Abhyanga, the Ishti Jyotishmati Taila has to be used for Abhyanga, and also Nasyam can be done, which is with the Taila which are Vatakna. So initially Snehana, Svedana, Samshodhana, everything can be done, and later Lekhana has to be done in the area. Then it has to be approximate, like it has to be like Sivana has to be done together, and later we can do the Vranavat Chikitsa. In Khanda-Talu, it is being told, it is explained in Sushruta, Shosho Atyartam Diryate Chapi Talu Shwaso Vada Talu Shosha Sapitat. And so it is being told that when there is Shosha in the Talu, so it is causing this Khanda-Talu, and it is again caused by the Vata dosha, and Shwasa can be an associated condition. And the treatment is told as Snehasvedo Talu Shoshe Vidishcha Anila Nashana. So Vada Vyadhi Kriya has to be done, or Vatahara Kriya has to be done in Khanda-Talu. The next congenital anomaly is imperforate anus, or like anal atresia, which is being explained. So it is an anorectal congenital malformation where distal anus and rectum as well as the urogenital tract is involved in this congenital defect. So this, in this condition, there is absence of an anal opening resulting from arrest of rectal descent during the 4th to 16th week of gestation. So 1 in 5,000 birth, we see this imperforate anus, and noticed initially as failure to pass the meconium. But at birth, we always check for the anal patency with the feeding tube to just check in if the anus is patent and see the meconium stains on the NG tube. So otherwise, it is failure to pass the meconium. And it can be associated with other congenital anomalies like bacterial deformities, vertebral anal cardiac, tracheoesophageal, renal, and limb malformations. So types, basically they are classified as low and high. So if the rectum is traversing the puborectalis muscle, we can call it as an low anomaly. And if it is rectal atresia, or the rectum ends up above the puborectalis, it is called as the high anomaly. And in low anomalies, you can see covered anus, ectopic anus, stenosed anus, membranous stenosis. And in high anomalies, anorectal agenesis, rectal atresia, or cloaca as such is present. So the assessment, newborn examination at the time of birth, we see absence of anal opening, or by USG or X-ray. This is also called as invertogram, where an opaque thing is kept on the site of anal opening, expected site of anal opening, and we see the gas shadow in the intestine to see where the rectum has ended up, and the distance will be calculated to see the extent of the anomaly. The management is surgical correction. Obviously, we have to go for surgical correction, and anoplasty has to be done. A neorectum will be formed, and later dilatation will be done. Till then, a colostomy will be done, and fecal matter will be collected then in the colostomy bag. So, or posterior sagittal anorectoplasty is also a method. So, the complications can be problems with controlling of bowel function, or sometimes constipation. So this is correlated into Sanniruddha Guda, where Vega Sandaranad Vayu Vihado Gudamashritaha Nirunnati Mahashrodha Sukshmadwaram Karodicha. So due to the Vega Sandarana, Vayu get vitiated, Apana Vayu to be very particular, and it is causing an obstruction in the Mahashrodha, or the GI tract, and it is causing a Sukshmadwaram. So the opening gets smaller, and due to the Marga Saukshmya, Margasya Saukshmyat Krichrena Purisham Tasya Gachadi, due to the minute structure of the marga, there is difficulty in passing of the motion, and it is called as Sanniruddha Gudam, and it is difficult to treat. And the treatment is told in the treatment aspect, it is be told that it has to be treated just like Niruddha Pragasha. So the treatment of Niruddha Pragasha is Niruddha Pragashe Nadim Lauhim Ubayodo Mukhim Dharavim Va Jatupratam Grita Abhyaktam Praveshayet Parishege Vasamajja Shishumara Varaheyo Chakratailam Tadayojyam Vadagna Dravya Samyutam Trehat Stulataram Samyak Nadim Praveshayet Shrodo Vibardhe Devam Snigdhamannam Cha Bojayet Vitvava Sevani Mukta Sadhyak Shadavat Ajaret. So what is being told in the Niruddha Pragasha, it is in the Mutra Marga is getting obstructed. So Nadi has to, or a Nadi Yantra has to be used, and it has to be like as we do a dilatation, we have to insert this Nadi into the anal region, and we have to keep increasing the size of the nadi, and also the what you say, the area has to be anointed with the vadagna dravya yukta taila, and the shrodas has to be like enlarged, or shrodo vivarde devam, and also the patient has to be given with snigdha anna etc. for maintaining the snigdhatva, and also sadhyak shadavat. So we have to treat the condition as sadhyovrana. So we are moving into the end of the session, where the last one and the important one in the congenital anomaly is hydrocephalus. As you seen in the figure, whatever you see is hydrocephalus, where there is a fluid which is accumulated in the head. So we know the production of CSF is, it is produced in the choroid plexus of the lateral ventricle. From there, through the foramen of Monro, it is being taken into the third ventricle. Aqueduct of Sylvius takes to the fourth ventricle. Again, there is medial and lateral foramens taking it to the spinal canal, and then it is reabsorbed by the arachnoid villi in the venous sinuses. So, if at all there is any obstruction or distortion in this normal flow and production of this the CSF, there can be hydrocephalus. So either there can be overproduction of the CSF due to any of the anomalies like choroidoplexus papilloma, where there is overproduction of the CSF, or there can be decreased absorption of the CSF. So any condition which is leading to the decreased absorption. Also, when there is an obstruction, the fluid can get accumulated. So usually we see hydrocephalus as a part of Arnold-Chiari malformation, which is a syndromic condition, and also the Dandy-Walker syndrome, where the brain contents are pushed into the spinal canal. So you see the hydrocephalus sitting, and it is classified as congenital, acquired, or communicating or non-communicating, where in the congenital condition, as I told, in Arnold-Chiari malformation or stenosis of aqueduct of Sylvius, or in Dandy-Walker syndrome, we see there is hydrocephalus. Acquired hydrocephalus can be due to a post-intraventricular hemorrhage or the intracranial hemorrhage, or due to any of the tumors or ruptured aneurysm or TB meningitis. So all these conditions can give rise to the acquired hydrocephalus, which is not identified as under a congenital anomaly. And the other classification is very important, where it is classified as communicating and non-communicating, where communicating is non-obstructive, which means there is no obstruction in the pathway, but either there is an increased production or reduced absorption. But in non-communicating, what happens? This flow of the CSF is getting obstructed due to any of the conditions, which is leading into a obstruction and the collection of the CSF in the cranium. So these are the two classification, and very important signs which is explained in hydrocephalus are sunset sign or McEwan sign, which can be asked very specifically for 3 marks. So sunset sign is, as you see there is a deformity in the eyes, where you can see that in the lower margin of the eye, you see the eyeballs is being pushed down due to the increased intracranial pressure. And McEwan sign is when you percuss the skull near the junction of frontal, temporal, and parietal bone, you hear a sound of a cracked pot. It is called as the cracked pot sign or McEwan sign. And one more important clinical feature you have to remember in hydrocephalus is periventricular ooze, which can be a hallmark in the diagnosis for the obstructive or non-communicating hydrocephalus. And the treatment is, whenever there is a collection of fluid, what we do is we channelize. So shunt has to be put in. So the shunt are ventriculoperitoneal shunt, ventriculoatrial shunt, or lumboperitoneal shunt, where in ventriculoperitoneal shunt is the very commonest kind of shunt what is being used. So before the surgical management, we can go for the medical management even to delay the surgical treatment, where you can go with the medicines like diuretics like furosemide, and also we can decrease the CSF secretion by acetylcholamide, and also CSF absorption can be increased by the isosorbide kind of medicines. So this is how a ventriculoperitoneal shunt will be put in directly from the ventricles to the peritoneum, where the fluid can be drained out. So this is correlated to Jalashirshaka, where it is being explained in the Baishiji Ratnavali 98th chapter, where the Baishiji Ratnavali extensively explains the condition of Jalashirshaka, where the Nidanam is identified as Dushtambupana, and Krimi, Asatnya Bhojana, and Pavana dosha. Because of Vata dosha, it is being told, and Sanjiyate Yat Kramataha. So it is being told that there is abnormal accumulation of the Sneha Amsha in the Shiras, and it is being told Prayaha Shishu Nam Upajayade. So in all ages, very especially in the Shishu, it is being seen and there is very progressive collection of the sneha in the shiras, and it is also called as Shirshambu Roga, and the prognosis is told to be Dushchikilsya. And in the Purva Rupa, it is being told as Jihva Malatyata, Gadavit, Daurbalyam, Nidradhikyam, Nishwasa Madhye Pudigandatvam is seen. And in the Rupa, Acharya is explaining so much of the Lakshanas, where we can just highlight on the Vishamakshi Tara, which is very much similar to the sunset sign, which we have already explained in the clinical features. And there are many other Lakshanas like Shiro, Ruja, Krishna Purishata, Mutralpata, etc. And also Vamanam. So just remember that the signs of increased intracranial pressure is headache, nausea, and vomiting. So all these three are explained in the Rupa as explained in Bhashyaratnavali. And it is explained as Shirshambu Roga. So Jalashirshaka and Shirshambu Roga are synonyms. And treatment is told as Rechanam, Mutra Pravartakam, and Rekta Doshaharam. So we have to do Rechana and Mutra Pravartaka kind of drugs has to be given, and also the Asra Doshahara. So the Rekta Doshahara Chikitsa has to be done. So yoga is Pita Mulyadi Kashayam as in explained, and coconut oil can be given internally, Rasatailam Lebam can be given. So these are the medications what is explained in Jalashirshaka. So these are some of the questions which were very frequently asked from the syllabus points. So explain in detail about the common birth injuries in neonates and management. So birth injuries very specifically like enumerate the birth injuries and also explain about the Upashirshaka or the Caput, Succidanum and Cephalohaematoma was asked. So it can be asked for 10 marks. And Jalashirshaka with a modern correlation, I think almost 8 or 9 times this question was repeatedly asked. Also, the Upashirshaka with relevant correlations where you have to write about the Caput, Succidanum and Cephalohaematoma too. And difference between Cephalohaematoma and Caput Succidanum is repeatedly asked. Herbs palsy asked for 3 marks. Birth asphyxia and management asked for 3 marks and also for 5 marks. Cleft lip asked for 3 marks. Sanniruddha Guda and treatment asked for 3 marks. Sunset sign very specifically asked. Atrial septal defect and neural tube defects together asked for 3 marks, where you have to like concise these topics into a according to the mark and explain the things which is being included in the topic. So thank you for all of your patient listening. By this we are concluding the session, and thank you for the opportunity, the Panchajanya team.
Am I audible, ma'am?
Yes.
Thank you, ma'am. Thank you for this wonderful session. From on behalf of Panchajanya team, I would like to thank you, ma'am. On your busy schedule, also you came here and you made the session for a better understanding. So, if any questions and further any issues, I will we will be directly forwarding the questions, and further answer will be forwarded to that particular students, ma'am.
Okay. Anytime.
Thank you, Ian. Thank you
Okay.
for this session, ma'am.
Okay. Thank you so much. And I'm
Thank you,
very
ma'am.
glad to have this opportunity with you. Thank you all and all the best for your exams.
We will further hoping for your upcoming sessions, ma'am.
Yeah, definitely. Yes. Good
Thank you,
night.
ma'am.
Okay.
Good
Thank you.
night.